Primary hypertension is a consistently elevated blood pressure of 140 systolic over 90 diastolic, which is found to have no underlying medical cause. Jonathan Jones is a 53-year-old male with no medical conditions, doesn't take any medications, and has no allergies. His family history consists of cardiovascular disease and diabetes mellitus type 2. Jonathan has a poor diet, has been a heavy smoker for the past 35 years, is a carpenter who runs his own business, and was divorced 7 years ago. All the signs we have collected from Jonathan, besides his blood pressure of 146 on 104 millimeters of mercury, are within normal range. Jonathan's symptoms include persistent headache, fatigue, and a feeling of his heart beating in his neck and ears. The cardiovascular system, the nervous system, the adrenal system, the respiratory system, and the endocrine system are all involved in primary hypertension, and these will be detailed throughout our presentation.
Essential hypertensive patients, it is the renal system's inability to excrete the excess sodium imposed by high salt diets. There are 4 mechanisms that cause changes in BP due to salt intake. These are excess sodium intake resulting in hypertension, retention of renal sodium, the release of agostine, and amplified activity of the sympathetic nervous system.
The renal system moderates blood volume and as well as the diameter of blood vessels, thereby affecting both cardiac output and peripheral resistance. This is maintained by the renal agostine-aldosterone mechanism.
Increased alcohol intake has been positively associated with primary hypertension in males. This is primarily due to increased activity in the sympathetic nervous system, causing increased heart rate and vasoconstriction. Alcohol also has an effect on the renin-angiotensin-aldosterone system through the increased levels of angiotensin II and aldosterone. Availability of nitrous oxide, which is a known vasodilator, in the blood can lead to vasoconstriction, causing an increase in blood pressure.
Family history. Studies indicate that 30 to 60% of the pathophysiology of essential hypertension is related to family history, and that there is a strong association among siblings and between parents and offspring. There are also various studies that explored mutations in genes and their correlation in predicting an increase or decrease in blood pressure.
Smoking tobacco is a known effector as it causes vasoconstriction by the activation of the post-organic neurons. As a result, there is a 2 to 3-fold increase in plasma epinephrine, interfering with the diastolic and systolic blood pressure of the human body.
Gender. It has long been discussed about gender differences in the development of essential hypertension. Many studies have revealed that males have a higher blood pressure than women, regardless of race, ethnicity, or country of origin, and therefore the prevalence of the disease increases. One study concluded that between the ages of 50 and 69, men's prevalence of hypertension remained greater than women, and that coronary events are twice as likely to occur in men than in women. Age. It is widely known that as men age, the prevalence of hypertension increases. Essential hypertension usually occurs after the age of 40, with 25 to 30% of the adult population suffering with the condition, with the percentage increasing to 60 to 70% of the people beyond the age of 70. It is suggested that this increase in prevalence could be due to the stiffening or hardening of the arteries that is associated with age, family history, and numerous amounts of environmental factors.
Stress biomarkers have shown to be present in patients with essential hypertension. Stress increases sympathetic nervous system activity through increased noradrenergic neuron firing in the hypothalamus. This response leads to increase in blood pressure. Hypertension has been linked to arteriosclerosis through the narrowing of blood vessels. Development of arteriosclerosis has been positively linked to long periods of stress. Stress increases mechanical load on the heart and has also shown increased beta-1 adrenoreceptor-mediated endothelial injury leading to dysfunction, which all increases the risk of hypertension. Multiple factors contribute to the development of primary hypertension, with most of these attributed to environment. For many of these factors, the pathophysiological mechanism has only been suggested, not confirmed. Jonathan, our patient, has many factors, both alterable and non-alterable, which together have greatly increased his risk and then development of primary hypertension. As there are so many factors with potential contribution to primary hypertension in Jonathan's case, lifestyle changes and management with antihypertensive medication will be the most likely treatment pathway.